Welcome to PG Pulse, Press Ganey's podcast on all things healthcare, tech, and human experience. In this podcast, we'll be joined by some of the best and brightest minds in the industry to discuss challenges, share insights, and innovate the future of healthcare. Thanks for tuning in. We hope you enjoy the conversation.
Welcome to the second day of HX24. We have a great session, and our topic is around digital transformation. Let's try to bring it down to action and what makes it real. And I figured the only way to really get a real perspective was to get a Nurse Evangelist and two CIOs up here on the panel with me.
Hello, everyone. I'm Emily Barey. I work at Epic.
Good afternoon, everyone. I'm Daniel Barchi. I'm Chief Information Officer of CommonSpirit.
Hi, everyone. My name is Novlet Mattis, and I'm the Chief Digital and Information Officer at Orlando Health.
Let's jump into our topic of digital transformation. And lots gets written about it. Lots gets spoken about digital transformation. Let's put a little bit of detail and some focus. Let's start with what you're each excited about and what really sort of makes you sort of want to look forward and get involved in all the technology can offer. Maybe Emily, you can start?
Yeah, happy to start. So, of course, one of the things that we're working on at Epic is how to leverage Gen AI. And in that Gen AI category, I think one of the most exciting things that our team recently showed me was a proof of concept around how you could take patient education materials and patient instructions and immediately put them in the person's native language and grade level. And when I thought about empowering patients and promoting health equity, it just took my breath away. So when I think about the tools that are out there and where we're going, it's those kinds of use cases that get me most excited.
That's great. Daniel?
I'm excited about technology that's not so cutting edge, but is more embedded in what we do. So I'm the CIO who doesn't want to go out and buy more technology. I mentioned before that we're complex. We've got 19 electronic health records. So think about optimizing 19 different instances and electronic health records. It's really difficult to do. So we're trying to get down to one. We need one ERP. We need one of this, one of that, instead of many. And when it comes to advanced technology, I'm not excited about new startups that we're bolting on or new processes we're forcing nurses or doctors to jump into. I just want it embedded in what we do. What we need to do is adopt things that nudge us to excellence in the tools that we have. So I'm most excited about technology that's going to come embedded in what we use every day.
Yeah, I'm most excited about the fact that technology is more and more becoming a game changer for our clinicians and our physicians. So again, back to, I'm there with you. I really don't need a lot of tools. I don't need a lot of technology, but taking a platform approach and then using that to be able to have physicians get more pajama time.
Daniel, I want to pick up on something that you said. I've been a long admirer of your work at Yale, New York Presbyterian, now at CommonSpirit. You've often talked about how it's easy to get distracted with a big, shiny object. I know you sort of touched on it, but how do you sort of set priorities? How do you figure out how to take an organization as big as CommonSpirit and get it pointed not only in the right direction, but pointed together?
Well, I'll share one thing that I like sharing. It's a little bit of a story. I read about a really great photographer who worked for National Geographic, and somebody asked him once, what's the best camera in the world? Expecting to hear like a Nikon SLR with an f2 stop lens or something like that. And the response was, the best camera in the world is the one that you have in your hands when you need to take a picture. And that really stuck with me. And so it's not about an exciting new tool that a physician needs to go and log into when he or she needs to do something. It's what's there in the moment. And so much, to answer your question about what we have in technology and what we need, is what's there every step of the way. When I joined CommonSpirit, I thought, boy, we're big and complex. How do we wrap our minds around meeting our needs at the same time advancing with the most advanced AI and ChatGPT and tools like that? And so we created a model that's based on Maslow's hierarchy. So everybody knows Maslow's hierarchy. You have your basic needs, physiological needs, food, air, water, shelter, and then you have companionship, and then love, and then self-actualization. So you move up the scale. To me, the advanced technology we're talking about, the AI, is the self-actualization at the very tip of the pyramid. But you need everything below that to work to get there. You can't go out and spend $100 million on AI and think, our health system's going to run really well now, right? What you need is the core infrastructure that's up and reliable. It's easy for everyone to log into. You've got the security, you've got the communications, you've got the EHR and the ERP, and then you've got the data on top. So that's my focus, to use that model to say, let's meet all of our needs, not just focus on the bright and shiny.
Got it. Makes a lot of sense. Now, Novlet, you have, I think, a somewhat similar philosophy. You've come through a year where you've collected a lot of hardware, HIMSS awards, Most Wired awards, some Epic awards, and I think we were talking about it. You mentioned the idea that it's not, again, about one big thing. It's about a lot of small things and sort of having a plan. Tell us a little bit more about that execution, how we get things done with the everybody focused on let's do digital transformation.
Absolutely. I'll double down on what Daniel just said. It's really working to make sure that your foundation is strong and it's solid, it's rationalized. You don't have... I came into the organization 6 years ago, and we had over 2,000 applications. We had desperate EHR, definitely not as much as you have right now. And so we really needed to get our house in order. So we built out that foundation. And so that's why it was not just one product, because Epic was our big thing. We had to replace all of those disparate health, EMRs with one comprehensive health record, and we chose Epic. But in order to do that, we had to make sure our wireless was good, all our PCs were good. I moved, the data center out and, moved things into the cloud. We solidified that. And then we say we're taking a platform approach. When we put Epic in, can Epic do it? Can Epic do it good enough?
Emily, you and I have spoken quite a bit in the past about nursing, the impact of nursing. I think it would be fair to say that if you're not going to get the nurses on board, it's probably not going to happen. Yet we're faced with all this technology, Gen AI, you brought it up. Everybody is thinking that, okay, maybe we're going to use these auto-magical solutions of the computer replacing humans. I think I would be correct in saying that healthcare is a pretty labor-intense industry. Give them some thoughts in terms of how you think this massive amount of technology with perhaps this promise to reduce labor is going to meet a labor force in healthcare.
Yeah. I think the thought that I've got around Gen AI and really any of those tools, predictive models for the nudge, decision support, those are members of the team, and what will be left behind, and this is me quoting others, but I really agree with it, what will left behind is the people who don't know how to use those tools effectively in their role. And so, in fact, in the Maslow's hierarchy, one of the things I think a lot about is, do we have a workforce that's ready to use these tools and ready to think about the team in a really different way, where you may have things related to AI, you may have different kinds of skill mix, you may even have a robot, as we are seeing now in some of our organizations. So I think that's one of the pieces, is building from the ground up, is do we have a workforce that's ready because the technology is ready? The other piece I would think about is thinking bigger. So particularly in nursing right now, there's a lot of really great ideas related to how do we use this to improve the handoff shift to shift, or how do we use it to draft a note and make it a little faster at the end of the shift to have the goals automatically completed. Those are great projects and they're a great place to start, but honestly, it's not big enough, particularly when you think about the work of nursing and really the work of care coordination. I loved the discussion earlier from the Tampa General CEO. And what I mean by that is thinking bigger would mean really thinking about using these tools for interoperability to expose the whole team's work, so a much bigger set of information, putting it right in the workflow and letting us really pick up that holy grail of the patient's story, not just across our organization, but really across our communities, so that we can start focusing on things like functional health and like the person's goals, because at the end of the day, that's where the value really is. We won't change that curve without getting to those pieces, and that's where nursing sweet spot is. And I also think it's where patients want to be. They want to work on their goals, on not just what we think they should be working on. So all that to say, I guess, Darren, I'm pretty excited about where we're headed. Okay. But I do think it's thinking about these technologies as a member of the team, and then really understanding your scope relative to those team members, including the patient, because this tool they'll take advantage of this tool too, I think, and really be empowered by it.
Okay. Well, I'm going to sharpen the question and get ready because I'm going to throw it to everybody.
Okay.
So is Gen AI going to replace people in healthcare?
No, I don't think so. I don't think so. I think it'll be a solid team member, but I don't think it'll replace people. I think it'll replace people, again, who don't know how to use it effectively or who organizations haven't really figured out the right use cases. I love Novlet's analogy of like several small things. That makes a lot of sense to me, but I don't think it'll replace people.
Okay. Daniel?
I do like to focus on people. I've got to put a plug in here. If we're talking about patient experience, I've had the great opportunity to work with people like Rick Evans in New York Presbyterian and Connie Clemens Brown at CommonSpirit. And it's people who make things happen. Nurses make it happen. And so you got to figure out what's going to do to the workforce. All right.
Green clap for that.
Applause line. I'm not even a clinician. That's great. You have to make sure that the clinicians, especially the nurses, are brought into what happens. I'm not fearful for jobs with technology. I do feel like it'll help with what we do. But if you think about introductions of major technologies, it never fundamentally changed the workforce. The analogy I like to use is from 1900 to 1915, the number of horse and buggies versus automobiles in the United States, they're in inverse, right? On top and on bottom. But there was not in 1907 a major layoff of horse and buggy drivers. Everybody's kind of picked up how to drive a car, right?
Yeah.
And over time, we all just got better and better at it. When you learn, if you learned how to drive a Model T, then by the 30s, you knew how to drive a Packard, and you never had to go to driving school. All of us started off with a mobile phone, then a flip phone, and then a BlackBerry, and then an iPhone. None of us went to school for it. The technology kept coming along and made us much more efficient. So I think the technology is going to get more and more advanced, but I think that only the most advanced of us need to know how to program it. The rest of us are just following along, moving up a step. So I'm not afraid of impact of technology on the workforce.
I think we just become knowledge workers. I mean, we're already knowledge workers. It's just a new generation of knowledge workers, my take.
Novlet?
The words that we're using are that generative AI or AI in general will augment. So you'll hear things like co-pilot. It will automate. I have seen where I don't have a lot of programmers, but, tasks that would take them 2 weeks to do, they can do in 4 hours right now because they can generate code and it will optimize, right? So our ambient EHR is a big deal, right? The fact that a physician can, use their phone to generate notes and then it can go into the EHR. That's how AI is really making a difference. It's not going to replace physicians. It will not replace nurses or anyone else or anybody in IT who might be fearful of this. It's going to augment them, it's going to automate, and it's going to optimize what they do.
So is this, Emily, one of these paths where we're going to get everybody back to the top of their license, one of our favorite phrases to utter in healthcare?
Yeah, I was just thinking, for those of you who like lean, I agree with Daniel. I think it's going to take a lot of waste out of the system, which should move everybody to higher value work, maybe not even higher scope of practice work or full license work, but just everybody working to much higher value work. And I think one of the pieces of higher value work is maybe just as a counterpoint that maybe there is a human that answers the phone or a human that has one more minute to talk to the patient and talk to the family, so that as we're saving time, I worry a little bit that translates into you can take one more patient on your caseload, or you can round on one more patient, or you can kind of fit one more x-ray in. And I'm hoping that some percentage of this time goes to higher value work, which is engaging and learning and supporting the family. And how we do that and how we measure that, I'm not entirely sure, but that is my hope when we think about taking the waste out of the system.
And, I think that our fear is that we're all in agreement that we have to leave the humanity and we have to put the people sort of at the center. How are we going to adopt all of this technology while really sort of maintaining that at the end of the day, it's really about the humanity for the patient and demonstrating caring? I think some of you have sort of talked a little bit about this idea of the best technology disappears into the background. Give me some thoughts about how we're going to go ahead and do that and really leverage technology in that way.
I can get started, and I think we were talking just before we came up here about, we can have all of these great technology. They're pretty slick and, we put it in front of a physician or in front of a nurse. And if they don't adopt it, if we don't train them, and if we don't help them to get through it, and also make it easier. I think another word that was used is ease of use. We're very big on that. So that's some of the ways that I think we have to make sure that all of this technology and all of these capabilities and, artificial intelligence, the human at it, they will still have to adapt to it. And change is hard for people. Change management is hard. So we also have to work on that as hard as we work on investing in new tools and technologies.
I think we need to be respectful of our workforce and our patients and acknowledge that there are no quick fixes. There is technology that will help improve and perhaps give minutes back, or as Novlet said, have some fixes will help us along the way. But I think being honest about it is really important. Darren, Novlet, and I were all CIOs at one point before we moved to Press Ganey. And at some point in our career, we were all asked, well, why do we need to buy Cerner? Why do we need to invest in Epic or in Allscripts? I understand that in 2004, Google's going to make a platform that'll lay over on top of all of this. And can't we just wait until Google solves that problem? And the answer is, unfortunately, no. We have to do the hard work of the core infrastructure so that the technology allows us to advance what we do. And I think that's the best way of acknowledging what happens.
I'm going to pull on the thread of the power of technology, and we all know that AI is fueled by data, and large amounts of that. I'm sort of thinking about how this is all going to work in healthcare and some responsibility that we all have to make sure that that data is the correct data. I think we've all learned to use the word hallucination in a new context. Tell me a little bit about how you're all thinking about ensuring the data is safe and it's the right data as we begin to put lots of energy around what AI can do for us.
Daniel's looking at me for some reason.
Very dangerous. You go first.
So I think first and foremost, like any clinical decision support tool, there needs to be engagement of the clinicians who are helping to author or helping to apply that tool. So even piggybacking on your last question, Darren, I think if the nurses aren't at the table to understand what it is first and foremost, and then how it works, I think that's where the real risk is. The second risk, of course, is the ease of use question that was brought up on the last panel, really making sure that it's the right time, the right place, and does the person on the other end, really, are they the right person? And I think it goes back to this knowledge worker idea in my mind, where in that Maslow's hierarchy, we need a workforce who can be brought into that table and appreciate or understand and full participants. And today, I'm not sure that's always the case with our nursing workforce. And so we need to invest in them on how and why these tools exist, how they work. So I think bringing the folks to the table, making sure that they're educated to know what it is that they're looking at, getting it into the right place and the right time, of course. And then the transparency, right? At the end of the day, it needs to be really transparent. What's happening? How did we get to that number? How do we get to that recommendation? And who generated it? Is it powered by CommonSpirit? Is it powered by Epic? So it's that transparency right in the workflow. I think the piece that groups also oftentimes miss and that we've been focusing a lot on is then what's the response? So there's sort of the alerting and the response, but then what do we do about that? How are we going to measure and monitor it and make sure that closed loop is always happening with really high reliability? So to that end, the care and feeding of these tools, I think it's been pretty easy to kind of get live and go live and sort of keep moving. I think these are the types of tools that are going to really force a level of rigor, not just on maintenance, the way that you might think of taking an upgrade, but really understanding how they're working and what their impact is. So those are probably the 3 or 4 things I think that make a big difference in how to use the tools effectively.
It is, and one of the ways we do, some of the things that we're doing is engaging the patients in the design of the experience that they will have. So, I'll work with, our marketing team and our design team when we're going to be doing anything that will impact, my chart or impact how they will interact virtually, through a virtual visit or virtual sitting for their family. We ask the patients, we have a committee, I forgot what it's called, but, our marketing team runs a group that they go out and they say, give us some input into doing this. And so
I don't want to brag, but they use our digital tools.